Hello, good morning.
Good morning, Dr. Pat.
How are you, Grace?
Good.
Like my new camera, very wide angle.
Looks very nice.
I was getting complaints of flickering. This works. I guess we're waiting for Perna and Uzo, and that'll be it.
Sperm back.
Did you say something, voice of Circe?
I was just confirming that Pern is back. Things should travel over the weekend.
I don't exactly know what you just said, but okay. Did you say she's not joining us today, or?
She should be.
Okay, and then I guess Uzo's the only other one. You can see my screen, right? The full EP conference, right?
Yes.
Yep.
Okay, great. Another minute and we'll get going. All right, I guess we'll just get going.
Good morning, Dr. Pat. Uzo is taking a personal day off today.
Okay. She's taking a personal day. Okay, thank you. Let's get going. So this is an EP study from some time back. Thought we would just go through it. So this is a 12-year-old with a history of intermittent tachycardia for 1 to 2 years, had documented SVT in the emergency room that had been responsive to adenosine. Unfortunately, we don't have any tracings. And the child was prescribed atenolol during the pandemic. And this was never actually taken by the patient. Again, the heart rate was reported to be between 200 and 210. And patient apparently continued to have episodes lasting less than an hour for the next 6 to 9 months. And for that reason, the patient was elected to have an EP study and ablation, so never actually took medication. It's not an uncommon story. Excuse me. So we'll go through the case today. So the first thing we usually show is the baseline electrocardiogram. And particularly in any patient who's going to undergo an ablation, we're always concerned about the conduction characteristics before we get going. This is important because you want to know what you're responsible for and what the patient is responsible for. And so in this case, this is the baseline electrocardiogram. And you can see that the intervals are normal. The PR interval was 145 milliseconds in baseline. Now, when we're doing an EP study, as you know, we're always trying to build a case for what the patient might have. And so we take all the evidence that we gather, and we use that in order to solve the puzzle of what it is that is wrong with the patient. And one of the first things that we observed when we were placing catheters, as you know, in our lab, usually after we create a fast anatomical map using the Carto ablation catheter, the next thing that we normally do is place the coronary sinus catheter. And during the placement of the coronary sinus catheter, the patient had one or two PACs. And do you have any thoughts regarding the PR interval with these PACs and what that might imply? So I'm going to ask Perna what you think. It's clearly these are PACs because the P wave morphology is not normal for sinus. So any thoughts on how this might help you, or at least lead you in one direction of thought?
So when I'm looking at the surface EKG, the PACs definitely look prolonged as, not the PAC, PR interval looks prolonged as compared to the one that you showed in the baseline EKG.
That's right. And so if you saw with a PAC that the PR lengthened substantially, first of all, is it normal for the PR interval to lengthen with a PAC?
I have not seen PR interval prolonging with PACs.
Well, what happens when we do atrial extrastimulus testing? Aren't we putting PACs into the...
Oh yes, we try to see where are we Venki barking in that sense.
Well, when we put PACs in, right, we're looking for the AV nodal effective refractory period, right? And as we put the PACs in, what happens to the PR interval?
Yes, in that case, it increases and it continues to increase, then it stops conducting.
That's right. And what is that? What do we say? What do we describe that kind of conduction as?
Decremental property
Right.
of the AV node.
That's right. That's decremental AV nodal conduction. So on the one hand, you could say that these PACs are doing what an AV node normally does, which is that they are causing some PR prolongation. But the interesting aspect of this is that these PACs are not very early, right? I mean, like this PAC is long after the T wave, and yet the PR is very long, right? I mean, if we look at the prior beat, the sinus, it's a very normal PR. And then when we have this PAC, we see this very long PR. So when I saw this during the procedure, my thought was, is it possible that this is a sign for dual AV nodal physiology? Now, again, we do not know that from this tracing, but it kind of got me wondering if there was a slow pathway in this patient's AV node. So that's the first datum that we have in our mind, is that PACs seem to conduct with a very long PR interval, for what it's worth.
Dr. Paz, could
Yes.
the PR be prolonged here because the AV node is getting irritated or no?
Absolutely. It could be that the catheter placement itself could cause AV nodal injury. That happens with some regularity when you put catheters in. That's certainly possible. Although at this point, you notice that there's only one catheter in the heart, right? Which is the coronary sinus catheter. And so it's possible that we might have struggled and pushed and, and it's not uncommon that we ding the AV node, something we really don't want to do when we're placing our catheters, because if we even cause transient, thankfully, when you touch a catheter to the AV node and cause some kind of an injury, it's virtually always transient, not 100%. If you try hard enough, I'm sure you could injure someone's AV node. But usually it's a transient event, but it could be transient, like lasting an hour or two. And if that's the case, it'll make it impossible to do an EP study or an ablation in the patient. The other possibility for why the AV node conducts poorly, which we surmised in this case was the more likely, was that the patient was under very deep anesthesia. You know, one of the advantages of doing pediatric ablations is that our patients are asleep, so we don't have to talk to them, and the patient is comfortable and relaxed, and most importantly, doesn't move, particularly when we're ablating something near a very dangerous area. However, one of the downsides is that anesthesia has electrophysiological effects on the AV node, as well as pathways and other electrophysiologic phenomena. And so, you know, generally speaking, in a perfect world, we would like our anesthesiologist to use the least amount of anesthesia so that the patient is comfortable, has no memory of the procedure, no discomfort, but has as much adrenergic tone as possible. And when this procedure started, as I recall, there was actually, the AV node was quite, it appeared as if there was some significant slowing in the AV node. So it's a very good question you're raising, and we'll see some evidence for it in a moment. And here's the first piece of evidence. So we start pacing. So now we have a catheter in the high right atrium. You see, I don't have catheter in the His, and we have catheter in the coronary sinus and in the right ventricle. Now, as soon as we start pacing the atrium, Josie is doing an atrial threshold. We notice that at cycle like 700, that the AV time is very prolonged. This is a PR of about 300 milliseconds. So that always makes us wonder, is it possible, in other words, what is the differential diagnosis of this observation? Because we've really done very little. And I will tell you that my recollection is that the catheters went in very easily in this particular case. So we basically have a very long PR interval as we're pacing. So the possibilities are that there was a transient ding of the AV node His-Purkinje system, resulting in a very long PR interval with pacing at a very slow heart rate, right? A cycle length 700 is not very fast. Another possibility is that the patient is under deep anesthesia. And because we couldn't tell, even though I thought it was much, much more likely to be due to the anesthesia, I decided not to place the His catheter until we saw some improvement in AV conduction. Because most of the measurements that we do, we can do without a His catheter. And His catheter, of course, is sitting, pushing on the AV node and the His bundle. And so if there was any chance whatsoever that the catheters themselves were causing an injury to the His, my decision was, at least for the first half of the case or first part of the case, while we were doing our baseline testing, I would not place a His catheter and only place it if it was necessary. For example, if the patient had AVNRT, or if we decided that the pathway that was there was close to the AV node. And so perhaps somewhat unusually, you're going to see that we do a lot of our testing without the presence of a His catheter. Okay. So now we start doing atrial extrastimulus testing, and we have to do it at a very long cycle length, here in this case at 900 milliseconds. And that's because the AV node is not working very robustly, as demonstrated here. We're already in what you could call a slow pathway already. So we have to start at a very long cycle length. So we start pacing and doing atrial extrastimulus testing at 900, 800. Now, we don't have a His here. Normally, we would measure the A to H interval, but we can use the PR interval or the AV interval as a surrogate of the AH and assume that the HV interval will remain constant during extra stimuli. So here we are at 900, 800 with a PR interval or an AV interval of 120 milliseconds. And then we put a premature into 900, 790, and we immediately see a very large increase in the PR interval. So we went from a PR of 121 to a PR of 277 milliseconds. So, Perna, what is that an example of? What would we say that is?
So if there is a jump more than 150 milliseconds, we say it is twin AV node physiology.
More than 50 milliseconds. I thought I heard you say 150, but it's that's correct. If there is an increase in the AH interval of greater than 50 milliseconds for a 10 millisecond decrement in the extrastim, or what we call S2, then we would call that consistent with dual AV nodal physiology. And so in this case, this is an example of a patient who has dual AV node physiology. Now we remember that a real percentage of healthy normal patients have dual AV node physiology, but this is consistent with the initial observation we made when we saw a premature atrial contraction caused a very long PR interval. So we now know in our mind's eye that there is dual AV node physiology. Now we go down to 780, and interestingly, we go from 277 to 316. So we almost have a second jump. And then finally, at 900, 770, I'm going to ask Grace Kong what happens here.
Sorry, Dr. Pesta. So it looks like we reached our AERP.
Well, you mean the atrial effective refractory period? Is that what you mean by that term?
Yes.
Well, we're pacing the A, and we see all of this, and actually this looks like a P wave. So are we capturing the atrial?
We are. So we're just not conducting to our ventricle.
Right. So it's not the AERP, but it is an ERP of one type. What type of ERP is it? What happens? What is conducting from our atrium to our ventricle? How do we conduct normally?
Through the AV node.
Right. So this is the AV node ERP. Okay. So, so if you're capturing the atrium and you do not conduct to the ventricle, then we're blocking in the AV node usually. If, however, we were to put that atrial extrastimulus in and we did not capture in the A, then you would have been correct. That would be the atrial ERP or the AERP. Okay, so that's pretty close. So basically, we now have an AV node ERP of 770 milliseconds. That's a very long AV node ERP, and the patient's resting heart rate under anesthesia was like 50 in a 12-year-old. This did not strike me as a normal resting heart rate, and I really thought it was very likely this was related to the anesthetic technique. We spoke with the anesthesiologist, and they informed us that yes, indeed, they could lower the anesthesia quite substantially. And so they started to lighten the patient up. And I also decided, in the interest of time, to start low-dose isuprel to see if we could jazz up the AV node a little bit in order to proceed with this study. So low-dose isuprel was started. The anesthetic technique was lightened. And now we're pacing at cycle length 860. You remember before we had a very long PR interval, even at this type of cycle length. So there is some improvement already in AV conduction. Here we are now at 810, so a little bit faster still, and we still see, lengthening of the PR, but as we know that AV nodes decrement as we get faster. Now we start to see something, which is as we're rapid atrial pacing and going from cycle length 800 down to 780, we notice that the PR interval seems to be changing. And Sergey, what do you think this is demonstrating here? What am I demonstrating with these little white calipers?
So the PR interval is prolonging.
That's exactly right. Yeah. So what is that a sign of?
It's a sign that it's being conducted through the AV node.
That's correct. And what do we call it when the PR interval lengthens as the atrial rate gets faster or the cycle length falls?
So that's not decrementally conducting. That's the opposite of that, I think.
No,
Yeah.
no, it is
That's
decremental conduction, but what do we call it when the PR starts to lengthen like this? Well, what would you expect is going to happen to the next beat or
that
two?
there will be a dropped beat. It'll be so it's a wanky buck.
Yeah, so it looks like we're about to wanky buck, right? So the PR is lengthening quite substantially. And when we get just a little bit faster, you can see here that I measure out the PR is 153, then 194, then 250, then 260, and then finally this this paste complex. This paste complex even longer still. So it's getting longer and longer. And then finally, when we get down to cycle length 690, we have these very long PR intervals where the P wave is now buried in the T wave, so we don't even see the P wave any longer. And then finally, we come to this paced complex where there is no conduction to a QRS. So this is, in fact, wanky buck at 690. So the patient is clearly conducting better than they were before, with the anesthesiologist lightening the anesthesia with the tiny amount of isuprel, but we're still not pleased with this degree of AV conduction. This would still be very abnormal conduction, although perhaps normal in somebody who is under general anesthesia and is still quite deep. And so I asked the anesthesiologist to lighten the anesthesia further, and we also increased the isuprel. Here we are with rapid atrial pacing on moderate dose isuprel, and this is now, I believe this was like cycle length 500 or maybe 480, and we see that the PR is very long now. In fact, we are wanky bucking here. So this paced complex is conducting to this QRS, this paced complex to that QRS, this paced complex to that QRS. So in this situation, what we would call this over here is sustained slow pathway conduction, where the PR is actually, I say it's about equal to the R interval. It's actually longer than the RR interval, right? Because the PR is from here to here, whereas the RR is from here to here. So when you have with rapid atrial pacing that the PR interval is greater than the R to R interval, that is the true definition of what is referred to as sustained slow pathway conduction. So this is sustained slow pathway conduction, and this would be considered to be good evidence for the presence of dual AV nodal physiology. And then we do see that with this paced complex, there's a paced A that does not conduct to a QRS, and then this paced complex conducts again to this QRS. So this is also wanky buck.
Dr. Pass, I had a question. How would we, if you just saw this tracing without any other things that we saw, how would we know that this P is not conducted to the QRS right next to it? Because it's too short?
Because it's too short. Because it's too short. There would have to be WPW, I guess. Also, if you look carefully here, the QRS and the atrial electrogram are on top of one another. In fact, so it's unlikely that it could be conducted. In fact, it's impossible. Okay. All right, so now we jazz up the isuprel. Now we're conducting quite a bit better. The patient is a fair bit lighter under anesthesia. And so now we're repeating atrial extrastimulus testing again, because at this point we have still not induced even one beat of tachycardia. So now we're on moderate dose isuprel, but we have a lot of evidence already. I should also say that I didn't show you this tracing, but in the baseline state, there was ventriculo-atrial dissociation. We did not see any VA conduction at all. So the data we have at this point is we see clear evidence for dual AV node physiology, both through atrial extrastimulus testing as well as through rapid atrial pacing, where the PR was greater than RR, suggestive of sustained slow pathway conduction. And now we're going to do atrial extrastimulus testing a little bit more normally on a moderate dose of isuprel. So here we are at 500, 310 with an AV interval of 99 milliseconds. And you see I'm still not placing a His catheter because I'm not yet convinced the AV node is okay, although it's obviously markedly better than it was. And then we put in, we go from 500, 310 to 500, 300, so a 10 millisecond decrement in S2, and we see an AH jump or an AV jump from 99 milliseconds to 172 milliseconds. And that would again be evidence for dual AV node physiology. So again, for any drop in 10 milliseconds, if the AV or the AH interval lengthens by more than 50 milliseconds, we call that dual AV node physiology. And now at 500, 260, coming down even farther, we have an interesting observation. I'm going to ask Dr. Walia, what do you think has happened here?
Let's see. So we pieced the atrium, but we did not conduct.
Well, look at the surface ECG. Did we conduct? Here's the pacing spike.
Okay, that's okay. So that's the prolonged PR that conducted. And then we didn't capture, then we didn't.
We stopped.
Yeah, then we stopped.
But what's happening here? This is what the normal A and V look like, right? Does that look the same in these beats?
No, does not.
How does
the AV is much longer.
right? Why is that? Why is the AV longer? Just for completeness.
Why is the AV longer? Because we switched to a slow pathway.
Correct.
Yeah.
Right. Decremental conduction.
Decremental conduction.
Right. And what is happening? What happened to the ventricular electrogram? It looks quite a bit different, doesn't it, than the prior beat or the beat afterwards?
Yeah.
Why is that, do you think?
My fellow is helping me here. Is this an echo beat?
Yes. Yes. Your fellow, who shall remain nameless, is correct. So what's happening here is, this is the atrial, like let's look here. This is the atrial electrogram. And this is the ventricular electrogram, right? We see it on every beat, A and V, A and V, A, V, we can't see here. So, but here the A looks like all the other A's, but this V does not look like this V or this V. Do you agree with that?
Agree.
Yeah, and so what's happening is that there is atrial depolarization that's occurring actually almost before
with the before the V,
or simultaneous with it. And so this is like, now this could be atrial reentry, like you could just have essentially like an atrial flutter beat, or more likely this is an AV nodal echo beat. Okay, now we call it an echo and not a tachycardia beat because it's going down the slow pathway, presumably up the fast pathway. But then we don't call it, so when it comes up the fast pathway and then does not conduct onto another QRS, we call it an echo. But if it were to conduct to another QRS, we would call it a tachycardia beat. Okay. So it's an echo if all you see is the reentry in the atrium, but it's a tachycardia beat if that reentry then conducts to a QRS. So this is an echo beat. And by the way, this is as much tachycardia as we were going to see in the entire case that day. Okay, so now we decide to do ventricular extrastimulus testing because now what we're seeing is that there is in fact ventriculoatrial conduction on isuprel and with much lightened anesthesia. So we're starting with ventricular extrastimulus testing, and we see that at 500, 350, we have VA conduction. This is the V, and this is the A, and it appears as if the A is earliest in the coronary sinus. Now, some of these distal CS pairs are fairly competitive. That's because the coronary sinus catheter was placed so far out into the CS initially that some of the distal pairs were actually fairly anterior, near to the AV node. So here's 350. In the interest of time, this is 300. So we see that the VA interval is clearly lengthening. So again, I'll show you, look at this VA interval, and then this VA interval lengthens out even more. Again, consistent with the presence of retrograde decremental VA conduction. Remember that the AV node conducts decrementally both antegrade and retrograde. And then at 290, the VA interval lengthens massively. Again, I'll show you. This was 300, and this was 290. And so when we see this type of change in the VA interval, Neha, what would we call this for a 10 millisecond decrement in S2?
Again, the same, that there's dual AV node which would conduct retrograde as well.
Right, so exactly. So this is an example of retrograde dual AV node physiology, where the VA interval increased by over 300 milliseconds in this case, with a decrement of 10 milliseconds from 500 to 300 to 500 to 290. You don't always see this, but sometimes you do, particularly in patients with AVNRT. So now we have another piece of data. So at this point, the AV node seems to be working better. And so Rob gets some courage for a change and decides to put a His catheter in. So now we have a His catheter placed, and we measure our AH interval, which is 63. David, what is a normal AH interval?
Normal AH is 50 to 130.
That's right. And so we have an AH of 63, well in the normal range. And since we're hitting on David, what is a normal, our HV interval here is 43. What is a normal HV interval?
It's like 30 to 50.
Yeah, about 35 to 50 milliseconds, exactly. And so that is good evidence for the absence of pre-excitation. So let's now review the data, excuse me, that we have collected in this case. We have the presence of dual AV nodal physiology, both antegrade and retrograde, but again, healthy young people can have this and not have AVNRT. We have concentric AV and VA conduction, and I should tell you that I repeated everything with the His catheter in place, and it looked exactly the same, meaning that concentric means that the earliest retrograde conduction or antegrade conduction is near to the AV node. I haven't shown you this, but you'll have to take my word that we observed both AV and VA block with IV adenosine. And that's important because, as we know, accessory pathways are adenosine insensitive and AV nodes are adenosine sensitive as a general rule. It's not always true, but most of the time. We had an AV nodal echo. We saw this a few times during the case. And we have a history of documented SVT. This is important because everything thus far could still be seen in a healthy, otherwise healthy person, and they do not necessarily have to have AVNRT. But it was the presence of SVT that made us know that all of these findings could in fact be suggestive of a diagnosis of AVNRT. And during the case, I referenced this paper from my good friend Steve Fischberger from 2003. And the title of this paper was Radiofrequency Ablation of Probable Atrioventricular Nodal Tachycardia in Children with Documented SVT Without Inducible Tachycardia, which is exactly what this patient has. This patient has documented SVT, but has no inducible tachycardia. And in his abstract, he wrote that in selected patients, empiric slow pathway modification may be offered as a potential cure in children with recurrent paroxysmal SVT who are not inducible at electrophysiological study. Elimination of slow pathway conduction may serve as a surrogate endpoint, though it is not necessary for long-term success. And so in this patient who has documented SVT, who has no evidence for an accessory pathway, we have not proven that this patient has AVNRT. However, we don't see evidence for anything else. Atrial flutter is possible, but it's extremely unusual in a patient who has a structurally normal heart at this age. It's possible the patient has ectopic atrial tachycardia, but the fact that it responded to adenosine seems unlikely to be the etiology. And we never saw a PAC other than with catheter placement in this entire procedure. Does not mean the patient doesn't have EAT, but unlikely. So we decided, since we were already there, since the patient has a history of SVT that has been well documented, since we have no evidence for an accessory pathway, that we would proceed with an empiric slow pathway modification. Now, the downside of this is, as you know, when we're doing slow pathway modification, the way that we know if we've done enough is whether we can induce SVT. So typically we induce SVT, we do a slow pathway modification, and then we try again to induce SVT. And if we cannot induce SVT, then we make the assumption that we've done enough. But in this case, we do not have that marker for efficacy. So it's a somewhat unsatisfying approach, but at least we can feel that we've done something to reduce the chances that the patient will have SVT following the procedure. But we have to be obviously very, very careful, because we're not 1,000% sure that this is what the cause of tachycardia is. And in order to do a slow pathway modification, we have to place applications in the posterior septal region, which is always carries the risk for heart block. So we have to be very, very careful. So we put the catheter in the lowest third of Koch's triangle. And in our lab, we use, as you know, RF current to do AVNRT. Some prefer to use cryo energy, because the benefit of cryo is that it is reversible, meaning, at least initially, so that if you were to see heart block and you were to turn off the cryo fast enough, the chances are high that you would not be left with permanent AV block. But we generally, both Dr. Love and I, prefer to use RF current for this, with careful attention to the AV node during the application. And so we turn the RF current on, and I'm asking the question in this slide, what happens in the beats that have the red little symbol here? What is happening here? So I'm going to ask Dr. Grace Kong what she thinks is going on here.
Looks like we go into a junctional rhythm.
That's exactly right. So is that a normal finding when we're doing an RF ablation for a slow pathway modification? Is that a good thing or a bad thing?
It's a good thing.
Right, it's a good thing. But as in all things, a little bit is good. Too much of a good thing is bad. So what we see here is junctional acceleration. So we turn the RF current on. In the first beat we see, we have a normal AH interval and a normal HV interval. But on our second beat, we already see that the AH interval has shortened. And in fact, the His bundle is starting to be competitive with the A. So we have the A and the His essentially occurring almost simultaneously. Notice how the A and the high RA in the sinus beat is before the His, but in this beat, the His is before the A. So this is an example. Remember that junctional rhythm is generally acceleration of the His bundle. This is why when people have junctional ectopic tachycardia, if you were in the United Kingdom, we would call it His bundle tachycardia. And so what we're seeing here is junctional acceleration. Now, there are some electrophysiologists, in fact, I would say most electrophysiologists would say that if you see an A or a retrograde A following every His, that you can feel reasonably confident that if there is a His to A conduction, which has to be occurring through the AV node, right? Because the His bundle sits immediately below the AV node. So the only way to conduct from the His bundle to the atrium is through the AV node. So some would say that's in this case, since the His to A conduction is consistent in these beats, that you could continue to ablate and monitor His to A conduction as proof that there is also antegrade conduction through the AV node, because what we're looking at here is retrograde conduction from the His through the AV node up to the A. But because we know that there are some patients who have retrograde AV node conduction but have antegrade block, our preference is to atrially pace the patient in order to confirm that at all times there is documentation of AV conduction, particularly in a case such as this where we're doing an empiric ablation. And so as soon as we see this, we start to rapid atrial pace at a cycle length that is slightly shorter than the junctional rate. And you see now that we're pacing a little bit faster, that the AH interval is stable and there is an A before every H as we're delivering the current. Now, the downside of this is that we do not know if junctional rhythm is continuing. And so some would argue that when you start to pace, you don't know if you're junctional, and if you knew that the junctional were to stop after 3 or 4 beats, you might not put a full 1-minute application at this site. But my attitude and that of many electrophysiologists is that I would rather put one in a place where I saw junctional and know at all times that AV conduction is normal than put one in where I am relying on the observation of His A conduction to mean that there would be A His conduction. So I like to know that the AV node is conducting at every moment that I'm delivering potentially dangerous currents near to somebody's AV node, particularly in a child. So we did this, and just to show you the Carto map of this case, these red dots. This is the RAO projection and the LAO projection. This is the the coronary sinus catheter and the His catheter. And you see that all of these RF applications, most of these were only a few seconds in duration because they were lesions that did not result in junctional, but lesions placed in this area here did result in junctional rhythm. And so this is where we put them, and this would be considered fairly sort of the uppermost portion of the lowest third of Koch's triangle. And when we were done, we have an AH of 52 milliseconds, similar to the pre-ablation value, and an HV interval of 43 milliseconds, also similar to before. And at the end of the case, the patient was now Wenckebaching at cycle length 380 when not on isuprel and when not, and at a relatively light anesthetic technique. That's important. The patient still had dual AV node physiology, but the Wenckebach cycle length was significantly shorter than it was at the start of the case, meaning that it seemed like the fast pathway was conducting better. And that is often an observation that's seen during a slow pathway modification, which is that slow pathway modification sometimes causes or is associated with at least temporary improvement in fast pathway conduction. And I'm not sure if it's fully understood why that is, but it is a nice thing to see when the AV conduction seems to be actually even a little bit better. And as was the case before the ablation, we still could not induce SVT. So in this case, we don't actually know if what we did was going to work, but we did see some positive change in the AV node. We did not see any more echo beats. And so we're going to have to see. Time will tell whether this proved to be true. According to Dr. Fishberger's paper that we reviewed earlier, it should work, but we really don't know for sure. And we'll find out with time. And so I told the family that there would be at least, we would want to wait at least 3 months to see if the patient recurred with tachycardia. Does anybody have any
Dr.
questions?
Pass?
Yeah.
Yeah, sorry. So if the patients who've had successful ablations, by which I mean that they've been followed for the next few months and not had a recurrence of SVT, can still sometimes have dual AV node? Like you'll see them still have AV node, okay.
Yeah, and then that's a very good question because the question you're asking basically is, do we have to abolish the presence of dual AV node physiology in order for a patient to not have SVT? And the answer is no, we do not have to do that. That we can modify the AV node and still have evidence for slow pathway conduction, but not be able to clinically have SVT. And, you know, it's probably true that if you try as the electrophysiologist to get rid of slow pathway in every single patient with AVNRT, probably on average, the success rate of ablation will be higher for AVNRT. However, there is no question that if you are aggressive enough to try and ablate and completely get rid of the slow pathway in everybody who has AVNRT, there's no question you will have a higher incidence of heart block in that patient population. So generally, I think it would be wiser to just, that's why we like to have SVT before the ablation, because if we can easily induce SVT before the ablation, and after slow pathway modification, we can no longer induce SVT, in the vast majority of patients, that will result in a clinical cure. And the presence of dual AV node physiology, we've discussed already, is a normal finding in a lot of patients. And so wouldn't be terribly concerned if you still had that at the end of the procedure, as long as you couldn't induce tachycardia. In this case, you might make the argument that you'd want to be a little more aggressive and not have duals at the end as further proof that you can't have SVT. But the problem is that we don't really know in this case if the patient had AVNRT. And so to me, even though there's no question that doing a slow pathway ablation, being a little bit more aggressive, perhaps moving slightly closer to the AV node, might have resulted in a higher percentage likelihood of this not recurring. On the other hand, do we really want to take a significant risk with somebody's AV node in a patient in whom we are not 100% certain that it is AVNRT? I have seen a case of this where somebody had this situation. We did a slow pathway and they recurred. And it turned out that on a second EP study, they had another arrhythmia, in this particular case that I'm speaking of, ectopic atrial tachycardia, that was never before documented. So my attitude is that we should do something because we're already there. And we know for certain, based on the clinical history and the documentation, that the child does have SVT, but I would not be super aggressive about it, which is what we did here. So it's fine to have dual AV node physiology as long as you can't have AVNRT. And as long as we don't injure the AV node, which thankfully we did not. Any other questions before we call it? All right, everybody. Hope you enjoyed this EP case, and I'll see you later for a conference in just a few minutes. I hope everybody has a good day. Bye.
Thank you, Dr.
Thank you.
Bye-bye.